like to get into introducing our first speaker, who studied at Duke University Medical School, University of North Carolina, for a master's in public health and trained at Community Hospital of Chicago. He worked there for 5 years, then started his own practice, the Versailles Family Medicine in Versailles, Kentucky in 2007. He began screening all of his COPD and asthma patients after learning more about Alpha-1 from Dr. Kyle Hogarth in Chicago. Dr. Hogarth is a Alpha-1 clinical resource center there. He's been very active in screening his primary care population for Alpha-1, and he regularly speaks to other primary care physicians to increase screening for Alpha-1 among those physicians. So here to speak to you about Alpha-1 lung disease is Dr. Brian Smith. Thank you, Dr.
No, and especially from a primary care doctor's perspective, it's, we've got a disease, we know how to test for it, now it's a matter of convincing people to test for it, and so that's where, I run into most of my problems talking to primary care doctors. So anyway, that's me. And I took boards yesterday, so I didn't prepare my own slide deck for this presentation. I took the slides actually from Dr. Hogarth. I asked him if it was okay, and he said it was okay. And this is Dr. Hogarth, so it was prepared by him, and he is, a big guy at Alpha-1, and he's a pulmonologist at University of Chicago. Much more impressive than me, except for he has much less hair than I do, so we're in good shape there. Anyway, so what I'm going to talk about is partly a lot of his slides, and I'm going to also interject a little bit. There's 5 or 6 slides that I think are primary importance for primary care physicians and also just people to get the word out about the frequency and commonality of the disease. I'm a very casual speaker, so if you have a question, raise your hand, stand up, jump up and down, get my attention, and we can interrupt during the program if there's something that comes up on a slide. We'll also try to leave some time at the end. A lot of the slides, I hate to read to people, so a lot of the slides are self-explanatory. Basically, not all Alpha-1 patients are the same. Like I told you, I've got patients that are ZZ and they're 60 and 70 years old, and they're, perfectly normal, perfectly fine, no disease. And then you've got, my patient that I have on augmentation therapy, he's 42. And, of course, he had smoked and he's quit smoking now, but, it can come in a variety of spectrums, a variety of diseases. We just talked about this. This is a fancy picture of the Alpha-1 protein. And it circulates in the blood. It's made by the liver. There's a little bit made by the lungs, but the primary mechanism is in the lungs, where it will reduce the inflammation that is caused by infection or by smoking, thereby reducing the destruction of your body's normal immune system against the lungs. We make white blood cells when we have infections. We have white blood cells all around all the time. They go up when we have infections. They make a substance called neutrophil elastase. It creates enzymes that kill bacteria, but those enzymes can also eat healthy tissue. And so it's always in the body. We have a concept of homeostasis, which is where we have to keep things balanced. So part of us wants to destroy something. So in order to keep that in check, though, we have to have something else to reduce the effects of that. And so that's what we do. That's what the Alpha-1 does. We have the elastase that wants to eat up the infection, but it gets too excited, and sometimes it'll eat up healthy lung. And so we get the Alpha-1 antitrypsin, and then it comes and deactivates the elastase, and then that stops the destruction of your healthy lung tissue. However, when you don't have this gets out of hand, and there's a couple slides to talk about more specifically about that. So normally, you have, in a healthy Alpha-1 MM patient, you've got a little bit of elastase, but you have a whole lot of Alpha-1. and you protect your lungs that way, because we like to, the body, we've got two lungs, we only need one, we've got two kidneys, we only need one, we've got a liver that's 3 times as big as what we actually need, probably, right? And so the body has all these extra layers of defense, and so the Alpha-1, there's lots of extra Alpha-1 for people that have MM, and so it keeps you safe and keeps the elastase in check. However, when you don't make enough Alpha-1, the elastase then starts to win, and you get lung destruction. There's also some people that think that because you have less Alpha-1, you actually have even more elastase, and so that causes even more destruction than you would if you had a normal amount of Alpha-1. But that's what is the crux of the breakdown of the lung tissue. And what is tricky when you're in primary care is Alpha-1 symptoms are common. I mean, how many patients, and I'm going to see 30 patients in my office on Monday. 20 of them are going to have these symptoms. And so how do I decide which of them do I treat, which ones don't I treat, or which ones do I test, and which ones don't I test? Is it bacteria? Is it viral? You've got all these things, and then you've got, I got to worry about the pap smear, the mammogram, and the colonoscopy, and all this kind of, and their cholesterol, and their high blood pressure, and their diabetes. Alpha-1 keeps going down, 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 down. And so what I like to do in the primary care world when I talk to primary care doctors, when I talk to patients, is let people know that it's a common disease, and it's and the testing for it is very simple, very straightforward, and often free. So everybody's done spirometry, everybody knows or seen somebody do spirometry. You hold that thing up to your mouth and you blow in, and you blow all the candles out on the birthday cake, or all the leaves off the tree, or whatever the picture is, and so it creates that curve, and then the inhalation part of the curve. And so spirometry actually is one of those interesting things that in primary care, I don't know what the exact numbers are, but it's probably less than 20% of primary care doctors have one of those things in their office. So how do they even diagnose somebody with COPD or asthma, let alone Alpha-1? And so they rely on, symptoms. And symptoms, as you can tell, cough and sputum are, who doesn't have cough and make sputum? And then, so it's not until you get exertional dyspnea or resting dyspnea when and dyspnea means shortness of breath, when you're concerned about somebody having COPD, but by then, they're going to have stage 3 or stage 4 COPD by the time they have exertional dyspnea or resting dyspnea. And cat's kind of out of the bag, horse out of the barn, whatever the phrase that you want to use is, but, you're behind the 8 ball. And, chest x-ray shows up even later in the disease changes, and relying on, the pulse oximetry or somebody needing oxygen, that shows up also late in the disease. So you really have to pick it up with spirometry early. And so, a lot of patients, and to me it doesn't make any sense. Like, just to speak very callously about it, I make money when I do spirometry. How do you not have a spirometer in your office? So, if your primary care physician doesn't have a spirometer in their office, I think that's a reasonable question to ask. So, some of the history, some guy named Harvey. I can't believe this disease is not called Harvey. So that's what we're doing now, so we name diseases after people, right? So Harvey Sharp's disease, or Alpha-1 antitrypsin deficiency, 1969. Neonatal cholestasis, 20% of those with Peyer's disease develop slowly progressive fibrosis or cirrhosis of the liver later in adult life. We've got a hepatologist from the Cleveland Clinic, so I'm not even going to touch the cirrhosis part of that. This is where, these are the 6 slides that I really hit home when I talk to people to try to get them to understand that Alpha-1 is common, that it's more common than than diseases that we test for, on the newborn screen. At least in Kentucky, we do cystic fibrosis, and Alpha-1 is 3 times more prevalent than cystic fibrosis. Sickle cell, you hear about sickle cell all the time because those patients come into the hospital all the time, but that seems to be some regional variation. In Chicago, I took care of patients all the time with sickle cell crises. I haven't seen one patient in Kentucky with sickle cell crises, and some of that's demographic variations and whatnot. So I show this. I say Alpha-1 is out there, it's prevalent. This 100,000 patients is probably a low end. The way they came up with this 100,000 number is they tested blood that was donated in a blood bank in St. Louis. And so you can say, and then so you tested 1,000 people, and 10 of them came back, or one of them had Alpha-1 Alpha-1 ZZ, then you can extrapolate that to the United States and say, so there's 1,000 people that we tested, and there's 100 million people in the United States. I mean, these are wrong numbers, so that means there's 100,000 possible cases of Alpha-1. But, so who here has Alpha-1 and has donated blood? Okay, good. In the past, but since you got diagnosed, so generally speaking, the people that donate blood don't have COPD. I think it's even exclusion, and they're generally healthy people. So that's an underestimation of the prevalence of the disease. So if you think about how you would screen for Alpha-1 to find a prevalence, you're not going to test people that go give blood. That'd be like testing people that do 5Ks. Do they have CF or Alpha-1? It's you're skewing your population. You need to go to Walmart and test everybody that walks into Walmart, and then you can get a real prevalence of the disease. So when I tell people this, I say we know it's at least 100,000. We know there's only about 10,000 that have been diagnosed. So that means there's at least 90,000 patients out there that we don't know about. And I further go on to say, when I'm talking especially to primary care doctors, how many of your COPD patients see a pulmonologist? What percent? And in my practice, it's less than 1%, because the pulmonologist doesn't really do anything that I don't do, except bronchoscope people. And they don't have access to different medicines. They don't know, it's not like they give the flu shot better than I give the flu shot, or the pneumonia vaccine better than I give the pneumonia vaccine. So these COPD patients that have Alpha-1 are in my office. They're in the primary care physician's office. They're not seeing the pulmonologist until they're ready for a lung transplant. And by then, what's the point? I mean, there's still a point to augmentation therapy, but by then, the nice catching when their FEV1 was 60 as opposed to 30. And prevent the whole need to go on the transplant list. So my point of this is tell them it's common. There's lots of patients out there that haven't been diagnosed, and it's our job as primary care physicians to find them, because they're in our office. They're not seeing the pulmonologist.
Excuse me, do you prescribe augmentation therapy?
Yes.
Okay. Excuse me.
Yes.
When do you know to ask your doctor to get on the transplant list?
When do you know to ask your doctor to be put on the transplant list? That's a good question. I wish Dr. Hayworth were here to answer that, because I don't do that. When I would send somebody to a pulmonologist to be evaluated for a lung transplant or put on the list would be, their FEV1 is 40 or less, probably 30 or less. They've got frequent exacerbations despite maximum medical therapy. They're not smoking, and then I'd probably send them to a pulmonologist.
So it actually depends basically on your doctor.
Yeah. And it depends on the patient too. I mean, I don't know how many patients I have with an FEV1 of 30% and they still smoke. And so, what's the point? It's like sending an alcoholic to get a liver transplant. I don't think that's going to fly very well. So, it depends on the doctor, but it also depends on, if you've got Medicare, then you can go to a pulmonologist without your doctor sending you. Let's see, so the University of Florida test kit is the one that I use in my practice, just because that was the people that walked in my door first. It's free. this is kind of just a breakdown of the population. They've done 120,000 tests, probably more than that by now, because this was a couple years ago. And they'd get 22% or something besides MM. And out of those, you get breakdown of, MZ, MS being the most common, and then ZZ and SC and SS being, the next most common. My patient that I have on therapy is an MZ. You can treat MZs. It's not in the PI of any of the products that says it has to be a ZZ to treat. It can be somebody, as long as they've got a deficient allele and a bad FEV1, and most people would say they don't smoke, you can put that patient on augmentation therapy. And it's amazing when because I talk to the reps of some of the companies, and they'll have a pulmonologist that has a patient with, so traditionally the Z is, doesn't work at all. The M is normal, and the S is, like 50%, it works about half good. And so the pulmonologist this has happened twice now, had an SZ and an SS with an FEV1 less than 40%, and they didn't put them on therapy because they didn't think they qualified because they weren't ZZ. And, you scratch your head and look around and go, what? And it doesn't make that much sense. I think there's some history there when the augmentation therapy used to be, I think 15 years ago there was a shortage of it. From what I understand, I haven't been around that long. But, and so I think people rationed it a little bit, but now there's plenty of it, so I don't know why people wouldn't see that. And so you get that patient, you're like, so, anyway. Yes, ma'am.
Why is N-moles never moved?
So, N-moles mean like you got a rare, like an F or something like that? Or like you're blank? Yeah, that's a good question. I guess you would be in the other. So you're not enough to get your own little slice of pie. Does that make sense? Rare. Yeah.
That means I'm more special.
Exactly.
You get a slice of the pie.
Yeah. So, and then this is what you fight against when you talk to doctors about trying to increase their rates of screening is COPD, special emphysema, is only caused by smoking. It's the only thing that ever causes it. You're crazy, you think there's something else. So rare, I don't need to test my patients. If you've got it, you're going to have emphysema no matter what, which is also not true. So that means, if they don't have emphysema, then why do I need to test them? There are no effective treatments. I think we can all test in this room that we're on effective treatments. Once I get results, I only have to worry about the ZZ patients. Like I just said, I think that may be the way the PIs were written 5 or 10 years ago, but that's not how they are now. PI means the product insert that comes with the drug. I would never test a smoker because, clearly the lung disease is caused by smoking, not alpha antitrypsin deficiency. Older patients, so I go to a nursing home. Actually, I test my nursing home patients for alpha-1 antitrypsin deficiency that have COPD because obviously I'm not going to help them. They're not typically active enough to get short of breath, but it might affect the care of their kid, their grandkid, their extended family. And I can't say this enough when I go to primary care offices, is the test is free. Why not do it? So, a lot of people, physicians, will also screen for alpha antitrypsin deficiency. So there's 2 ways to test. You can test for MM, MS, MZ, ZZ, SC, SS, null, or the rare alleles. So you can do genetic testing, which is once in your lifetime because your genes don't change that we know of yet. or you can do what's like a blood count of Alpha-1 antitrypsin, the actual blood count of the stuff. So it's like a white blood cell count or a red blood cell count. But we know that the stuff changes based on how sick you are. So remember the earlier slide, it's a response to infection. So if you're infected, the stuff, you have more of the stuff in your blood. Even if you're a ZZ, you make a little bit of it. You have a little bit of the stuff in your blood. When do you go to the doctor? You go to the doctor when you're infected. So if I'm testing your levels, they're going to be falsely elevated. And so I'm going to have a false sense of security that you don't have Alpha-1 antitrypsin deficiency because I'm measuring the stuff. I'm not testing your genes. In addition, I have to test the stuff when you're sick, and I have to test the stuff when you're not sick. As opposed to the genetic test, I can do it whenever, and I only have to do it once in your lifetime, and it's usually free. So you're like, how do you not do this test? So and the next slide, I think I copied it on here. I don't think I did. So anyway, maybe it's the next one. But the point of testing levels is if you're seeing a doctor or you hear friends or you guys all know somebody obviously who has Alpha-1 and you're talking to your friend in California and you're like, yeah, go see a doctor, you should get tested because I'm your brother and I'm a ZZ, so there's a 50-50 chance that you're a ZZ or an SC or an MZ. And they go to their doctor and their doctor says, yeah, we drew a blood level and it was 100 or 90 or 50. You say, no, you need to go to the doctor and ask for genetic tests, because if the blood test comes back, I hope I had this, I don't know if I did, but anyway, it doesn't really matter. You can miss like 90% of MZs, or sorry, I think it's like 50% of MZs and 90% of ZZs by doing the blood level as opposed to the genetic test. So if they do go to their physician, and their physician is not familiar with the genetic test, you can get them familiar with it. And there's resources online. AlphaNet probably can hook you up with. I think you can even get kits mailed to you. So this is the other big slide that we talk about. 10% of the iceberg is above the water, 90% of the iceberg is below the water. 90% of Alpha-1 patients are out there undiagnosed. Our mission in primary care is to find them. And this is the simpleness of the blood test. You guys have all had your blood sugar checked. Just you prick your finger and you can test for Alpha-1 just that easily. Takes my staff 3 minutes to do it. Mail it off. You get the results back in a couple weeks.
Is there genetic testing also?
That is the genetic testing. I don't do the levels.
Is that the kit?
That is the kit. There's a couple of the kits, but yeah, that's the one I use. The one from Florida. This is kind of a schematic diagram of how they do it down in Florida. I think I'm going to run out of time, so we won't go into that in detail. Yeah, so this is the slide I wanted to show. I wasn't sure I put it in there. So 90% of the MZ population has levels greater than 90. So if your physician tests just levels, or if your brother's physician or your friend's physician tests levels, 90 is going to come back normal. 90 is, Quest or LabCorp or somebody like that. One of the big national labs says 90 or greater is normal. So if you do a level, I'm going to misdiagnose 90% of the heterozygous patients and tell them that they don't have Alpha-1 antitrypsin deficiency. And if you even increase it to 140, say I don't want to miss anybody, so I'm going to go up to, instead of 90, I'm going to use 140 as my cutoff for normal. I'm still going to miss 30%. So 1 in 3 patients I'm going to misdiagnose. And this test is not free.
My son done the memory test, but it also said in his letter that he was normal. But it also said because if you are rare and null,
right,
you need further testing.
Right.
So he probably needs to be tested.
Yeah, so that's a great example. That's a great question. So the question is, and we'll go into this slide then, but this one right here. So it's really expensive to do the genetic testing, but it's free to patients, but it's expensive to the companies that sponsor it. So one of the ways they make it cheaper is they only test for common alleles and common deficiencies. And that captures about 98% of patients. If it's a son, a brother, and you know you're an F or a null or a Q or whatever, you know you're one of those rare ones, then you can request a kit that's, instead of a dried blood spot where you just prick your finger, they actually will draw your blood and send it to the blood, and they'll do the full isoelectrophoresis thing on it, and they only do that at like 2 places in the country, and they'll even do that for free though. But that's what you need to do. You need to talk to your doctor and say you need the genetic genotyping, not the phenotyping. So, right? Sound good? Okay. I'm going to check everything with my specialist here. So, any other questions on that? Okay, so now we get back to Dr. Hogarth's slide, and it's about being a patient and how you guys can help yourselves, help us help you, and help yourselves stay off the transplant list. Because at the end of his slide deck, I talked to him on Thursday about his slides, and I had some questions. And what he drove home to me at the end of the slide deck, we're going to get there, is you don't want a transplant, because a transplant is you're kind of trading one disease for another disease, and we're going to go into the morbidity and mortality of people that have had transplants, and it's not ideal. So it's much better to catch the disease early in primary care settings, avoid getting your FEV1 down to 20 or 30 by augmentation therapy and doing the things I'm going to talk about right now, than it is to end up on the transplant list. Having said that, if transplant's your only option, then that's what you got to do. But there's some slides up there that he basically says are supposed to scare us from sending patients to him for transplant. So protect your veins, drink lots of water, because we need IV access for augmentation therapy, we need IV access for strong antibiotics, we need IV access for the strong steroids. Yeah, I think this one's the important one. It's, if you find a doctor that I'm only going to do levels, if you find a doctor that says, I don't believe in augmentation therapy, you need to find another doctor. So you need to find one that understands what Alpha-1 is, or at least is willing to learn about it, and then knows that when you get sick, you get sicker faster than a patient with just COPD. So standard therapies in COPD treatment, so these slides are from Hogarth, and they're based on studies done in COPD patients, not just Alpha-1 patients, because there are not enough Alpha-1 patients to kind of do some of these studies. Obviously, total smoking avoidance, and that just doesn't mean I can't smoke around you as your personal physician, but it means more doctors smoke Camels than any other cigarette. And I was reading this earlier. This is no casual claim. It's an actual fact based on the statements of doctors themselves by 3 nationally known independent research organizations. We like Camels. So, and then of course, everybody knows what happened to the Camel guy. And it doesn't say personal smoking cessation, it says smoking avoidance, because we know, especially for Alpha-1, cigarette smoke eats augmentation therapy. And so when you are even exposed to just secondhand cigarette smoke, your augmentation therapy is destroyed. And so It's so funny because I'm a family doc, so we treat kids, and we'll see kids with horrible asthma, and moms and dads, we go outside and smoke. They come into your office and they smell like an ashtray. And I'm like, when your kid is laying on your chest, sleeping, and you smell like an ashtray, you think that helps their lungs? You think it helps to go outside to smoke? I mean, it's better than smoking in their bedroom, but you gotta just stop. And then the next one is pulmonary rehab. I had to ask a couple questions about this. So what he told me is Medicare pays for 12 weeks of pulmonary rehab in a patient's lifetime with COPD. And so everyone here, if you haven't used those 12 weeks, you qualify for pulmonary rehab. And so you should go find your doctor, have them find a place, or you find a place, even better at being the doctor, you find a place that you want to go to, and you just come in and tell me where you want to go. That way I don't have to go find a place. And then I'll send you to pulmonary rehab. And you can go for 3 weeks this year, get tuned up, feel good, and then go 3 weeks next year, and you can do that for 4 years, or you can do 12 weeks all at once, however you want to do it. There's some extenuating circumstances. If you have major surgery, you can get an additional few weeks or something if you've already done your 12 weeks. But the point is, pulmonary rehab is important because they teach you, they spend time with you that no physician, nurse practitioner, PA can spend with you. They do. Yes, sir.
What do they do in the rehab?
Perfect. Did I pay you to ask that question? So what they do, it's monitored exercise and graded exercise. Not like you get an A or B, but like you start out walking like this, and then you walk like that, then you walk like that. Or, you're doing knees and you got knee problems. You're surrounded by people with emphysema and COPD, so there's support groups, education, nutrition. Nutrition is actually, you guys probably should have a nutritionist come and talk at one of these sometime, because nutrition for COPD patients is critical. There's certain things you guys are supposed to eat, certain things you're not supposed to eat. You guys low down on that? Good. I can tell there's 2 jokes I was going to make. One, I was not at a cardiovascular meeting because we had bacon, sausage, and eggs for breakfast. And 2, I was glad it's not a doctor meeting because you guys start at perfect time, like 9 o'clock. I didn't sleep until 8. Doctor's meeting we start at like 7 o'clock, and you're like, it's not vacation. Yes, sir.
How about alcohol?
Alcohol in moderation for COPD, I don't have a problem with it. And tobacco cessation, obviously, and tobacco avoidance. We probably should change that slide to avoidance. So endurance training, this is what they do. Like I said, I don't like to read slides. And these slides will be on the website, so you can, they're probably already on the website, actually. A lot of these places also will, after you've gone through your first 12 weeks and you've graduated, a lot of them, you can pay a nominal fee, like $25 a month or something, and you can keep going and using their facilities and exercising. You're just not in the program anymore. And so a lot of places will do that. I know we have both our physical therapy departments in my little town. They don't have pulmonary rehab, but they'll let people come and exercise there like a gym for $25 a month, which is less than you'd spend at Bally's or whatever.
Supposed to Springfield hire TheraCare. After you complete your therapy there, you can use their facility for a year free.
Wow. So TheraCare in Springfield, Ohio, use it for a year after you do pulmonary rehab. Complete the pulmonary rehab program. So, or anything, yeah. Great. Yeah, and a lot of places will do that just because they want you, they know it's good for you, and they want you there for that whole time. Education, they teach you about the medicines, they teach you to ask your doctor questions, they teach you to stick up for yourself, help you with advanced corrective planning, medication compliance. And then everybody there is in the same boat you're in. They may not have Alpha-1 COPD, but they may have COPD, and on the surface, those are very similar. And so, how do you get around the grocery store? What do you do when Walmart doesn't have any other carts left? That kind of thing. So it might, there's support groups there that can be helpful. And this is interesting. So walking on a flat surface, how long does it take you to get short of breath? And the people who did no rehab were 7 minutes. The people who did rehab were 13 minutes. So you doubled the exercise tolerance by going to rehab. Long-acting bronchodilators, inhaled corticosteroids. We know that these medicines work. We know they are effective, but you have to take them every day whether you feel good or not. If you have problems with them, talk to your doctor, talk to the pulmonary rehab people. They might be able to help. Oxygen. This was an interesting slide. So this is COPD patients, and percent alive at 3 years. And so that's that's one of my favorite statistics, is how many people are still alive. There's not FEV1, there's not short of breath, time to, are you alive or are you dead? And people who are prescribed oxygen 24/7, and they wore it, 75%, almost 75% of them were alive. People who are prescribed oxygen 24/7, and they only wore it at night, or they felt bad, or they never wore it, 25% more of them died. So 55% of them were dead in 3 years. So if you're prescribed oxygen, there's a reason why Medicare spends, I don't know how much oxygen costs, but it's not free. There's a reason why they do that, because it's effective. Vaccination. Everybody get the flu shot. I was going to bring my flu shots. That's what I thought about that actually yesterday. So everybody needs to get the flu shot. Everybody needs to get the flu shot. If you're over 65, you need to get a high-dose flu shot. It's different than the normal flu shot. It's got more antigen. It's more effective in patients over 65 because it has more antigen, and when you're over 65, your immune system does not work as well. If your doctor doesn't have high-dose flu vaccine, you need to go somewhere that does. Absolutely. Yeah. So the new guidelines for pneumonia vaccine are anybody over the age of 18 with pulmonary disease. So we're vaccinating our 25-year-old patients with just asthma with a pneumovax, and insurance pay for it. That's a great question. Pneumonia vaccine without kidney disease is every 10 years right now, 2 in your lifetime, and you're done. That recommendation has just changed in the past few years. Probably in 5 or 10 years, they're going to say, well, you probably should get a third one. And so, but right now, it's 2 in your lifetime after you turn 18. In the back. Pardon me?
Are you recommending whooping cough?
Yeah, we do. Yep. And the trick with the whooping cough is, so I certainly recommend it if you're going to be around newborns or anybody under 1 year of age. Problem is, insurance companies don't pay for it yet, and it's about $40. But you get diphtheria, tetanus, and pertussis. You should get those when you do the whooping cough booster, because it's one shot, and that's $40. The pneumonia vaccine was the question up here. It was every 10 years, so unless you have chronic kidney disease, then it's every 5 years. But right now the recommendation is that you only get 2 in your lifetime. And it's everybody over 18 in this room, except for people that don't have lung disease. So, and then the high-dose flu vaccine is everybody over 65. Medicare pays for it. They pay more for it than they do for the regular shot, so there's no reason your doctor shouldn't give you the high-dose flu vaccine. It costs me more, but they pay me more. There is a new pneumonia shot out, and it's made by the people who make the pediatric Prevnar, and it doesn't, there's controversy we still use the old one because it covers more serotypes. The new one is supposed to be better because it's more immunogenic, but it covers fewer serotypes. So, as long as you're getting one of them, I think you're in good shape. But there's 2 pneumonia shots now. One is Pneumovax, and I don't know what the brand name is. The other one is. Yeah. Shots. So everybody get their flu shot yet this year? All right, you guys need to get in and get your flu shot. We've seen cases already in Kentucky, and if it's in Kentucky, then it's definitely north of us. We actually saw cases this year of flu year-round. We saw positive flus in June, July, and August. So it's no longer as much a seasonal disease as it used to be. So everybody, by the end of next week, I pledge to get my flu shot by Friday. Right? Good.
Is there a safety for the whole year?
Yeah, actually, the new ones are. They'll do studies. They actually do studies on them. They'll draw blood 6 months, 9 months, a year, 5 years later, and even the new shots 5 years later are still about 80 to 90% effective. So it lasts a long time. Then you still need it every year, though, because it changes every year. Yes, ma'am.
Vaccinations, flu shots, every time I have, I've got my flu.
Right.
Also, my father had Guillain-Barré.
Yeah.
I don't know if that is a hereditary, if it could affect me at all. I know you're
Right.
vaccinated about,
Yeah.
you can't have any
Right.
vaccinations. So what risk am I taking because I take it?
It's a higher risk of hospitalization from flu. And so if you get flu-like symptoms, so the other trick with flu is if you get flu-like symptoms, if you don't get to your doctor and get tested within 48 hours, the medicine we have doesn't do any good. So if you start to feel like you have the flu, then you need to get into the doctor within 24 to 48 hours. And so that's Friday night, you have to go to an urgent treatment center or ER over the weekend. And you're not supposed to get sick, although we hear that all the time. They're dead vaccines, but the way that they work is they trigger your immune system to do something. So you do feel like you get a mild case of the flu often after you get the flu shot. And sometimes it's not mild. Yes?
If you consider to be a carrier, one of your children, male or female, you passed on to one or the other, whichever.
So if you're an MZ, M1Z, the question is, if you're an M1Z, are you more likely to pass it on to your male or female children?
I've already passed it on to my mother was a carrier. I thought I had she might have been I've already passed it on to my daughter.
Right. It is irrespective of gender. Yeah, so we need I don't have one, but we need a Mendelian genetic slide. Do you have one of those? No. Okay, so if I'll have to draw that out. I'll do that later because there's a pretty straightforward little picture that can give you the odds of you giving it to your kids based on what you are and what your husband is. So. Oh, sorry. 5 minutes. Oh, okay. Sorry. And they have a genetic counselor speaking at the end of the day. So she probably has a Mendelian genetics slide.
They can talk about lunchtime also.
Yep. I've got 5 minutes, so these are the slides that are talk about who gets lung transplants. Alpha-1 is 6%. Double lung transplants, 8%. And this is what it's supposed to, so you've got 100% of your people alive at the time of the transplant. And then you have, the highest rate of death right after transplant from, surgical complications or whatever. But the point of, we break it down, this is just for the Alpha-1 patients now. You started out with, so we'll just take the best case scenario, double lung transplant, Alpha-1 patients, start out with 1,000. At 5 years, 630 of them are dead. So you don't want a transplant if you can avoid it. And then this is, at 12 years, you can't read that, 68 of the 1,000 are alive still. So I don't want to scare you, but I want to empower you to get your friends and relatives who have COPD tested early in the disease, because I can help you a lot more if I find you at 70% as opposed to 20%. Surgery. So we've been taking questions throughout it. I've got like 2 or 3 minutes left. Augmentation therapy. You guys can talk to people in the back about that. We do it. We give them, it's a weekly injection. You got to get it every week. It wears off after a week. It changes the scale back so elastase gets itself back into line. And then I think this last slide is, so never on augmentation therapy, cumulative mortality, on augmentation therapy, cumulative mortality, big difference. And that is, I think that was ZZs, but I'm not sure. I have that in my notes somewhere else. And FEV1 decline, the normal rate of decline as you get older, you lose lung function no matter what. You don't smoke, you run marathons, you get older, your lungs get a little bit worse every year no matter what. They get worse every year no matter what at 30 mLs per year. When I give you augmentation therapy, your lungs get worse at 30 mLs per year. So it's the same as somebody who doesn't have problems with alpha-1 antitrypsin deficiency. This is a control group. They got worse at about 64 mLs per year without augmentation therapy. There's my kids, Carter and Alexa. So that's it. He's 3.5, she's almost 6. So, any questions? Yes, ma'am.
How does one go about doing that?
Best thing is make sure before you go to the doctor to get blood drawn or before you get your infusion IV, you drink a lot of water so I don't have to dig for a vein. Because the more times I poke you, finding access, the worse it is. That's pretty much it, yeah. Yes, sir.
As the lungs get worse, continue to get worse, what kind of effect does that have on the heart?
That's a whole other lecture. As the lungs get worse, what kind of effect does that? Yeah, as the lungs get worse, what kind of effect does that have on the heart? As your lungs get worse from COPD, the short answer is it causes heart failure with bad COPD because your arteries that go out to your lungs constrict. And so just like you have high blood pressure when we test it in your arm, if you have bad lungs from COPD or alpha-1 COPD, your pulmonary arteries constrict, and that's called pulmonary arterial hypertension, and that causes right-sided heart failure. So it can cause heart failure, I guess. Does that answer your question?
Is rehab more important now than it was back 20 years ago?
Yes.
Can you repeat that?
Is rehab more important now than it was back 10, 20 years ago? Cardiac and pulmonary rehab, we now know, do a lot of good. My dad had bypass surgery about 2 months ago, and he was walking, he can walk like 4 miles now because he has done his rehab. So rehab is very important.
What is the testing?
What is the testing for pulmonary hypertension? That's a great question. I think you have to do cardiac catheterization, right? Yeah, right heart catheterization. So, I think you can get a little hint of it from an echocardiogram, but to prove it, it's right heart catheterization.